we've had a tremendous discussion. These are, from the point of view of somebody who doesn't treat diabetes as an outpatient physician, exciting stuff. I mean, really good stuff. And before we leave, I want to ask each of you to give one last thought about diabetes, about these agents, to share with our audience, and we'll start right over here.
I'm excited to have a toolbox with so many tools in it to choose the right one for the right person along the lines that we've discussed today.
That's your last word. You want to amplify or add or?
What I can say is my suggestion would be to don't be afraid to treat. Treat not only to glucose targets, but to blood pressure and lipid targets as well. We've gotten such a wealth of wonderful medications that can be, again, targeted to that patient's specific problems. So personalized medicine has come of age, and I would just encourage physicians to be aggressive about going after people with diabetes and again, helping that patient to comply with their disorder.
Okay. And Dr. Rosenstock, the last word from you.
No, I want Carol to give the
Nope,
answer.
it's my choice. You
all
get to go
So,
first.
I fully agree with the personalized medicine. But I think that more importantly is personalized targets. To define very clearly with the patient what is the personalized target. And whatever the target is, I'm going to choose the right tools to get to that target. Asking the patient, respecting the patient's wishes for sure. But in the end, I'm going to give you the Rosenstock treatment for the future in looking at the crystal ball once we have evidence about it. And I think that 90% of people with type 2 diabetes will be well treated with one pill, one shot. And I would start everybody with a metformin and an SGLT2. And when that is not enough, I will use an injectable that is a combination of basal insulin and a GLP-1. You will start with metformin and SGLT2, one pill because you have fixed combinations that you can give it in one tablet, and then one shot. Because I cannot think of any reason to use insulin alone when we know that it gives you weight gain and it gives you hypoglycemia. And I cannot think of any reason why to use a GLP-1 that gives you a lot of GI side effects, and with that, it doesn't give you. So one pill, one shot will treat 90% of people with type 2 diabetes.
And I know you've been sitting here expectantly. This is your shot. You get the last word, Dr. Wysham.
Well, I hate to say it again, but I agree with Dr. Julio's last comment. This may be the first and maybe the last, but we'll state that. But I also just want to express the importance of primary providers out there getting familiar with these new drugs. They are very effective. Patients really appreciate the impact that they have on their blood sugars, but also on their weight, and that's very motivating for them to continue their weight loss efforts. I take care of lots of patients who come in from other primary providers, and when I talk to them, I don't know enough about those drugs, I don't feel comfortable using them, and I feel like they could expand their abilities and their patients would be so much more satisfied.
Well, I want to thank all four of you. A tremendous discussion. From my personal perspective, I see diabetics coming in as outpatients all the time to the operating room. We have diabetics in the ICU. It's a complicated disease, but it's not so complicated you can't figure it out with the help of people like these four that we had on our panel today. Again, I want to thank you for joining us, all four of you. Thank you, of course, for joining us as well. I'm Dr. Peter Salgo. We'll see you next time.